Most of the innovations at the University of New Mexico come from adopting innovations in different parts of the world. And I'll point those out. No school's innovation comes just from our own head. We see others and we pick and choose what we need for our environment. And that's why we're so interested in this conference leading to a collaboration of learning from each other. New Mexico is on the US-Mexican border, and it's surrounded by very, very conservative states that have treated immigrants very harshly. The majority of New Mexicans are Hispanic and indigenous. And so we have a much more liberal approach to education and service, which is very important. We have a very large in-migration from Mexico that is not legal, but they're important for our economy. In just these past few months, we have large numbers of children coming from Central America, coming right into our border, which has shocked our population, but it speaks about the terrible inequities and disparities that have to force us to consider new ways of collaborating with our partners. Our response can't be just legal and arresting people. It has to be development in our region. This is data which drives much of our thinking. In New Mexico, the one population that has the best screening and treatment for diabetes is the Native American indigenous population. The best screening and treatment. But they have the highest death rate from that disease. The best quality of care and the worst outcome. How is that possible? Because despite the high quality of care, it cannot make up for the years and decades of high unemployment, low social integration, low graduation from school, nutritional problems, social marginalization, all of the social determinants that make much more of an impact than the health service. And these are simply examples of social determinants that we've discussed in the last 2 days. And this simply, again, reiterates that most of our money is going to something that affects very little in health in the United States. But what we did not discuss is why we continue to put so much emphasis on so little outcome. And the reason is we make a lot of money just the way it is. And that's why it is a big political fight in the United States to take some of this resource and move it back up to what affects health. And that's our emphasis. If you take a look at education, you could actually go on to the internet and look up education health calculator, and there's a direct correlation between how much education there is in your state and how many lives you would save if you increased the graduation rate. There was a doctor who headed WHO's Global AIDS program in Geneva for 5 years. And at the end of 5 years, he made this very famous statement. If he were to make one intervention that would decrease AIDS in developing countries, it would not be vaccines, it would not be antibiotics. It would be to increase the number of girls graduating from school. And that's exactly what's happening in New Mexico. If you can increase the number of children graduating from school and having higher education, all of those social determinants are improved and health shoots up. Another area that is of particular concern in New Mexico is food insecurity. Food insecurity. In one of the wealthiest countries in the world, we have a very large problem of people not getting enough food and not getting enough nutritious food. And if you look at the inner circles, that's 10 miles from a supermarket. The larger circle is 20 miles from a supermarket. And if you're outside 20 miles, your likelihood of getting fresh fruits and vegetables is very slow, very minimal. And that's why in these areas of the state, we have the highest rates of obesity, malnutrition, poorly controlled diabetes, and hypertension, because the foods you access are fast foods, which are not nutritious. So we have to put much of our emphasis in New Mexico in setting up access to fresh fruits and vegetables. We had decided as an institution that we would have an overriding vision for every component of the University of New Mexico Health Science Center, the College of Medicine, nursing, pharmacy, and the hospitals. And we would all fit under this vision, which drives us. And it is a vision which influences our education, service, research, and policy, that we will work with community partners to help New Mexico make more progress in health and health equity than any other state by 2020. That's our goal. Now, this fits within the best of public health messaging, which is people can actually remember this. Most vision statements no one can remember, but this we remember. And it's the rule of 3-7-27. No more than 3 concepts said in no more than 9 seconds in no more than 27 words. This is our statement. And I'm going to explain how we do this, but our leadership is very frightened because each week they come to me and say, we're getting close to 2020. Are we getting there? Are we beating out the other states? Well, when we presented this around our state and we asked people all over the state, how are we doing? We always think we are terrific. But when we asked the communities, this is what they said. You are known as the University of Albuquerque, not the University of New Mexico. You come to us with a grant, and when the grant goes away, you disappear. You have no long-term commitment to us. You don't build on our local wisdom. You don't ask for our leadership. You come with your ideas and your leadership. And we never say no for fear you'll never come back. But you're really not asking us what our priorities are. And this was the most difficult one. You do not compare well to the agricultural college in New Mexico. We love the agricultural college because they have cooperative extension workers in every single one of our communities, and they help us with our growing better foods, better products, helping our children with 4-H clubs. You are nowhere to be seen. So we realized we have to be like the agricultural college in cooperative extension. So we set up the health extension program in New Mexico. So we have our agents learn everything about the resources at the University of New Mexico that would help the health of local colleges, local communities. But the local community decides what they need from us. We don't make that decision. The health extension coordinators link our resources with their needs. They also monitor how well are we doing. And are we reaching Vision 2020? Is it really true that we are making more progress than any other state? For the educational aspect, we do a very large amount of what we had described as pipeline development. If you were to make one intervention in terms of educational output, It would not be the curriculum change. It wouldn't be the support of communities after that. It would be who you take into medical school. Who you take has a bigger impact than anything else. So we now are taking students from every part of the state, and it's a fight to get the school to accept students of promise who are likely to go back, who have lower test scores. And because of this program, we now reflect in our student body exactly the ethnic makeup and the geographic makeup of our state. We started with 38% of our medical students coming from underserved minorities, and those were Hispanic, Native American, and African American. Now 53% of the students are of those minorities. It is the reflection of the state. We've changed the curriculum, and this is just a way of showing. Take 4 years and spread it out in one line. Every medical student now in New Mexico must graduate with a certificate of public health. And the reason is that we don't want students to only be able to take care of one patient after another. There's never going to be enough students or doctors to take care of the very large population. Every doctor, whether they're primary care or specialist, must have a community and population perspective to have a greater impact on health. At the graduate level, what we've done is we've decentralized our residency training in family medicine. Instead of having family medicine doctors trained in Albuquerque and they go back and forth, we've put their training all around the state. And the outcome is remarkable. 70% of the residency graduates from rural areas are now working in rural New Mexico. The biggest impact is not just the number of doctors in those areas, but the economic impact of a doctor in a small town. Every doctor in the United States in a small town generates $1 million of business and hires about 17 people directly or indirectly. That's a big business in a small town. And that has helped stabilize rural New Mexico. It's one of the important items that keeps state legislators interested in investing in this kind of decentralized education at the graduate level. We now, because of Vision 2020, look at every single county and say, what kind of health provider do they have, what do they need, and what is the gap that we have to fill by training locally? And this is an example of one rural county, and you can see there's, like for physicians, they need about 108 for their population of 53,000. They only have 60. We have to figure out how to train and deploy 48 more primary care doctors. And we can do that with every single health profession. So we are responsible for our part of helping their health service needs. We know that it is not enough to have wonderful education if you can't change the health service delivery. And if you look at the kind of delivery that we are now working on, the complexity of social determinants is so high that we can't do it just with doctors and nurses and traditional clinics. So we've created what we call a health commons, where the clinics respond to local health needs. And we have primary care, public health, behavioral health, oral health, case management, community health workers, all now working together in their community. And the community helps determine what the priorities are. This is what a health commons looks like. And what we have done in terms of social determinants is expanded the health team. And this we got from Brazil. somewhat from Kenya and other countries, and that is the use of community health workers in a very integrated way in our team. And I was watching, we were in Londrina, looking at the health workers, doing economic development, looking at all kinds of public health risks, but they tied it to their clinics. It wasn't just something outside, disconnected from the health care. And so we've set up now in our clinics, integrated with community health workers that do all kinds of social determinant interventions. They've developed a food co-op, they're developing urban gardening, housing renovations. Because poverty and unemployment is so high in these communities, they're actually teaching local people how to grow chickens and sell the eggs. They have beehives that are selling the honey, and they've even had a elementary after-school program to keep children in school and graduate. Almost every social determinant is now integrated into the clinics through collaboration with community health workers. Now, the big question is always, how do we keep graduates in underserved rural or urban areas? We can educate students in those areas, but do they stay? And our answer in New Mexico is you have to create almost mini universities where you have social as well as professional teams that all go together to smaller communities. And it becomes very attractive for graduates to go there because they won't be professionally isolated, they won't be socially isolated. And we've therefore taken this model of these heroes or health extension agents and developed around them teams and regional relationships so that you can send your students and your residents to these very, very good locations where you've made innovations in education, service, research, and policy. That's the next direction. This is what it looks like. Each of these hubs is organized by a health extension coordinator, and they work with UNM resources, local community resources, state resources, and their local health system. And that's where we do the training in these communities. But it's not just working with a local doctor, it's also being part of a larger system that's very attractive. And the number of graduates we now have going to these areas is very, very high. And they become our future teaching centers as well. Now, we also, because of Vision 2020, monitor the determinants of health and the outcomes and health of every single county and of our state. And these are national measures if we're going to hit Vision 2020. But because academic centers are very quantitative, they want to know numbers. So for example, we said, well, if we're going to jump 3 states worth up in the national ranking, let's say of primary care doctors, we would have to train 50 more doctors than we have in our state to jump 3 states worth. So we're working on that. If we were to improve our education, we would have to train, graduate 1,500 more students in New Mexico to jump 3 states worth, just in high school graduation rate. So that's what we work on. Here is what has become some of our outcomes. In terms of the diversity of the student body, I mentioned we've gone from 38 to 53% are now underrepresented minority, just like our state. We've improved our immunization rates from 68 to 76%. The primary care doctors per population has now shot up. These are all significant. We use a nurse advice line where everyone in the state can call for free to get advice. We get 15,000 calls a month. And lo and behold, the national rankings came out last year, and New Mexico jumped more than 46 states worth, not just 3. And we came in 4th So our leadership is very happy. We can actually become the state that makes more progress in health than any other state. We're on our way. So we are not criticized as much as we were in the beginning. Thank you.